And yeah, so we're going to overview our FDA-approved treatments, FDA-approved medications for treatment of opioid use disorders today. And that's the idea, to start to become familiar with them and kind of start to think about how we choose from between one versus the other. And I'll be sure to end with plenty of time, so that way we have time for the case discussion, which is really the heart of the ECHO model. And as those of you who have seen me present before certainly know, this is kind of one of the big take-home points I like to give, that when it comes to opioid use disorders, detoxification is not treatment. Simply detoxifying someone from opioids, which we often think about as treatment, does not actually seem to improve any long-term outcomes. And as that's, I think, Walter Ling from UCLA said it very eloquently. So I'm using his quote, right? Detoxification from heroin is good for many things, but staying off heroin is not one of them. In other words, not very effective. And so does it work for anyone, right? That's sort of the other question that often comes up. And it does seem to work for a small group of people. So how small a group are we talking about, right? When I say it might work detoxification alone without subsequent medication support, maybe up to 10% of people, it might work. The difficulty is that we think this is a group of people, the 10% were able to just be detoxified and not receive any medications and not go back to using illicit opioids subsequently, tend to be high motivation, tend to be relatively stable, but we don't have a good way right now to predict who that 10% is. And we know that up to 90% of patients who are detoxified will return to using illicit opioids within the first month or two. And of those that relapse, some will die of an overdose, right? And we can't really predict who that 10% are who are going to do well. And when the alternative is this severe overdose and relapse and hepatitis C and everything else that comes along with it, that's not a guess that I'm very comfortable making as a physician, right? I would like to know who those people are. And without that, it really puts us on shaky ground. And I think, and this is a CACO study that's highlighted here, in more detail. So this was published in the Lancet way back in 2003. And in this study, everyone has opioid use disorder. Half of the participants, right, are randomized to be maintained on buprenorphine for a 1-year period. And the other group is simply detoxified over a 1-week period and then maintained on placebo for the remainder of the period. And you can see that the group that's maintained on buprenorphine at 1 year out, about 15 out of 20, right? That's about, 75% of participants are remaining in treatment, only 5 dropouts and no mortalities. But on the other hand, the group that's detoxified and placed on placebo, within 2 months, everyone has dropped out of treatment. And 4 out of the 20 participants, roughly, right? So about 20% are no longer alive at the 1-year end of follow-up period. Pretty dramatic and I think sobering data, right? Here that we're looking at. So just something to think about. Right? So our medications keep people in treatment, and without medications, most drop out of treatment, which is bad, because when we can keep people in treatment, that's when we can help them in from a whole person perspective, right? If I'm able to keep someone in treatment, that's when I can treat their underlying post-traumatic stress disorder with, psychotherapy, for example. That's when I can treat their hepatitis C. But if I cannot keep them in treatment, I've lost the opportunity to help that individual. And without medications, as this slide shows, the chances of someone remaining in treatment are extremely and unacceptably low, right? Now, when it comes to opioid use disorders, so that's the first piece, that detox alone doesn't work. We got to think about maintenance treatment like we would for other chronic illnesses, right? Just like if someone has diabetes, we're not going to think about just detoxing them using metformin, for example, over a 1 week or 2 week or 4 week or 2 month period. We're going to think about maintaining that person on metformin. Opioid use disorders are no different. And just like with diabetes, for most people, medications do play a central role in the treatment of opioid use disorders. So we have 3 FDA-approved medications. Methadone is the oldest one that's been out there. It was approved for detoxification back in 1970, for maintenance treatment for opioid use disorders back in 1973. Then we have buprenorphine, which was originally approved, I believe, in 2003. And then we also have naltrexone. The oral form was approved in the 1980s. And what we use more commonly is the injectable long-acting naltrexone, also known as Vivitrol, which was approved in 2010. They're all effective, right? Methadone, buprenorphine, naltrexone, those are 3 FDA-approved medications. I start with methadone because, again, it's been around the longest, and in some ways it's been studied the most because it's been around the longest. And these are just some of the outcomes that I was able to pull together from a variety of literature that has been associated with methadone. And it's, I think, fairly impressive. Reductions in heroin use by about 50% conservatively. Look at this, reductions in HIV transmission 4-fold. Some increase in employment, reductions in criminal activity and incarceration, less high-risk behaviors, more child support payments. People are more likely to remain in treatment, more likely to adhere to hepatitis C treatment. The mortality is, in fact, reduced, and it's cost-effective, right? So some pretty good data there with methadone have been seen, kind of moving forward. And these are also some of the other benefits that have been associated with maintenance treatment in terms of high-risk behaviors, right? So you do see reductions in IV drug use, reductions in needle sharing, reductions in cocaine use, unprotected sex, multiple sex partners, commercial sex work. So I think quite a bit of data that's out there. This is an older study, but I like to use it because, this is something that comes up a lot in terms of engaging in criminal behavior. And it was 6 sites around the country, and UNM was one of these sites. I don't remember off the top of my head. This was well before my time. I don't even think I was in this country back in 1991. And I was in school. But UNM was definitely one of these 6 sites, which is just a nice historic fact. And you can see how dramatically, crime days per year reduced after people with opioid use disorder were enrolled in methadone maintenance treatment. Most of the crime days, were really associated with what needed to happen for people to use their illicit opioids, which at that time was primarily heroin. These are just some other thoughts that medication really can be one part of a more comprehensive treatment, right? And I think once we get people engaged, which we're able to do using medications, we can provide that more comprehensive care, including therapy, counseling, case management, healthcare. And we really want to individualize this, right? We want to see what the people's needs are and try to meet those needs using our interventions. So it's kind of the hook that leads to treatment engagement. But then once engaged, important to treat underlying illnesses, both psychiatric and medical, helping stabilize life, right? Through employment, housing, transportation, legal assistance, things like that. And just as importantly, then we can start working on creating those positive social networks, which are an important part of recovery, as are meaningful engagement in community, which often in my experience go hand in hand with learning coping skills, relapse prevention strategies, emotion regulations. And those are all the things we can do only if people stay in treatment. If we can't engage people, we've lost that opportunity. The other thing that I will point out, when we talk about the outcomes, and this has really been associated, I showed this in a previous presentation, but for those of you who may not have been there for that, right, is the reductions in mortality. So buprenorphine and methadone, which are 2 of our FDA-approved medications, are shown to significantly reduce mortality. And it's not just overdose mortality. It's also all-cause mortality, as well as suicide-related mortality. So I think these medications are incredibly life-saving. Certainly in the world of psychiatry, I cannot think of any other medication that reduces mortality, even nearly to the same extent. And even in general medicine, right, when you think about chronic illnesses, very few interventions are shown to reduce mortality nearly as robustly as methadone and buprenorphine seem to do in patients with opioid use disorder. So they're some of the most effective medications we have, and we remain reluctant to use them, right? So with that introduction, I'm gonna go a little bit, I'm gonna glance at the time. Okay, we're doing okay. Into our, just a little snippet of our FDA-approved medications, right? So I mentioned methadone, which is sort of the first one. It's been around since the 70s. It's a Schedule II medication. So it's highly controlled. And it's a full mu agonist. So when used, it binds to and activates our mu opioid receptors in the brain. And because of the regulations around it, it's a little bit strange, where if someone is going to use methadone for the treatment of pain, anyone can prescribe it as long as they have the appropriate DEA and Board of Pharmacy Schedule II certifications. It can be prescribed out of a provider's office to treat pain. I don't necessarily recommend it, but it can be done. But if methadone is going to be used to treat opioid use disorder, it cannot be prescribed, right? It can only be dispensed in a highly regulated and monitored opioid treatment program setting. And opioid treatment programs are also colloquially known as methadone clinics. As I already shown, it's a very effective medicine, but there are lots of barriers to it. You have to demonstrate at least a year of documented opioid dependence or opioid use disorder, and can't really use it for anyone under the age of 16. If someone is 16 or 17 years of age, you must have a parental consent, plus you must document at least 3 failed prior detoxification attempts before prescribing it. So some significant regulations. And I think the fact that it can only be dispensed from an opioid treatment program has created additional barriers to treatment, which is important to think about when we think about how widely opioid epidemic is raging in our country right now, and how difficult treatment continues to be to access, right? It's out of the medical mainstream, right? Many opioid treatment programs are, not integrated within larger medical clinics, right? So I think that's a major barrier. There is often stigma of specialized clinics, right? Of going to a quote unquote methadone clinic. There's stigma associated with it. Location of clinics. Right? There is one state in the United States that to this day doesn't have a single opioid treatment program. Here in New Mexico, we've got many in New Mexico, in Santa Fe, in Española, Farmington, Las Cruces. But what about the person who lives in, right, some of these small outlying communities? It's going to be hard to access methadone. We have patients at our clinic at the University of New Mexico that live 2-3 hours away. And because of federal regulations, sometimes, especially early on in treatment, they're asked to come in for observed dosing up to 6 times a week. Imagine how difficult that would be for any of us to accomplish if we did not live near an opioid treatment program. And I think that's one of the big barriers. And the fact that it's out of the medical mainstream, very difficult to coordinate care and provide that whole person care. Methadone can, however, be really helpful for some people who need that structure. I really think about methadone as the treatment option in patients with, very long-standing severe opioid use disorders who have maybe tried and haven't responded to something like buprenorphine, for example, right? So you need a stronger medicine. We also use it for patients who need that structure. It benefits them. To give a very concrete example, at our clinic, we have a group of patients with, severe schizophrenia, primarily disorganized type, who haven't done well in other treatment settings. Even, things like, assertive community outreach and things like that, they haven't really done very well, right? Like ACT teams, for example. But if we got them on methadone for their opioid use disorder, a ride service brings them in, they come in for their methadone, and when they come in, that's when we can have a psychiatrist assess them, have a medical doctor see them, give them an injection of their long-acting opioid medication, do their Ames exam, have them see a case management, things like that, right? So we can really organize care, and that improves outcomes for those patients. So that's a little bit about methadone. That brings us to buprenorphine, right? So I think what you see here is gradual erosion of limitations, right? Starting with, back in early 2000s, 2 decades ago, MDs and DOs could prescribe buprenorphine from their offices. That's the big benefit. That, unlike methadone, buprenorphine can be prescribed from someone's office. So initially it was MDs and DOs only. And only after doing a special 8-hour training and getting an X number, right? And there were patient limits. Then in 2017, the CARA expanded it to NPs and PAs, right? But with a 24-hour training, another barrier. Then the Support Act opened it up to nurse specialists, nurse anesthetists, nurse midwives, also with the 24-hour training. And what's happened now, right? If you aren't aware, the waiver is gone, which is, I think, full disclosure, I think it's a good thing. The waiver is no longer needed. Any qualifying provider, including MDs, DOs, PAs, NPs, other nurse specialists, and clinician pharmacists, really, can complete an 8-hour training, which we do provide, and once they've done, and they can prescribe buprenorphine already. Anyone can prescribe buprenorphine as long as you have a Schedule III license. In addition, the DEA has set for the training requirement, which is 8 hours of training, which are for everyone that you use for renewal of your DEA certification. So that's another elimination of barrier, and we will see how much that impacts access. Our hope is that that's going to really open up the access, right? Buprenorphine is sublingual, comes in films and tablets. There are implants, but those are currently off market because no one was using them. There are 2 now long-acting injectable formulations that are available in the market, for which is another, again, more treatment choices to individualize care, right? And I'm not going to go into too much about the pharmacologic details, which we cover in our other medications. I think the big take-home point being that buprenorphine is a partial agonist. In other words, up to a certain dose, it activates those mu-opioid receptors increasingly, but then it plateaus out. So there is a big advantage it offers in terms of overdose risk. The overdose risk of buprenorphine is very, very low and lower than any other opioid, right? And the other real benefit is that because of this office-based treatment it allows for this private, confidential, safe treatment within larger context of care, right? So you don't have to go to these costly out-of-town residential treatments or daily visits. Allows people to live their lives and work towards their sobriety goals, whatever they may be, within a larger medical context. It's about as effective as methadone at reducing opioid use. Treatment retention is slightly less, but I think in my experience, that's weighed out by some of the real benefits buprenorphine offers. It's safer. We don't have to worry about QTC prolongation as much. There are fewer drug-drug interactions, and it's certainly more convenient for the patients, right? And our third treatment is naltrexone, which is an antagonist. In other words, it binds and blocks our mu-opioid receptors. So if someone uses opioids, once the naltrexone is in their system, they don't get reinforcement. They don't feel the high. And over time, there's this extinguishing of drug-seeking behaviors. Both the oral pill, which is daily, and the monthly injection are approved by the FDA. That being said, the daily oral pill is not an effective treatment for opioid use disorder. Although it's approved by the FDA, in controlled studies, you get very low treatment retention, which is one of the big things we look at. So if we're going to use naltrexone to treat opioid use disorder, we should be thinking about and using the monthly injection. The injection given every 4 weeks. Once started, it's about as effective as buprenorphine, but it's a whole lot harder to initiate. Someone who's been using opioids has to go at least 7 to 10 days without using any opioids before naltrexone can be initiated. And that's a huge treatment barrier for many of our patients, and significantly more patients starting naltrexone never get their first injection, never get started compared to buprenorphine, for example. It's also very expensive. Thankfully, in New Mexico, Medicaid will cover it, but without that coverage, it can be, about $1,500, $1,600 a month, which is going to put it out of reach for many people, right? So this is just a reference slide in terms of how do we choose. So naltrexone, again, this is probably the least commonly used medication out of the 3. Many patients opt not to be on it. In control studies, when started, it works about as well as buprenorphine. It's clearly better than placebo, but in real world settings, the treatment retention, even with the injectable naltrexone, tends to be lower than that for methadone or buprenorphine. Also, unlike methadone and buprenorphine, both of which have shown robust reductions in mortality rates, to date, naltrexone has not been associated with improvements in mortality or reductions in mortality. So something to keep in mind. But some people are highly motivated. They want treatment without an opioid medication, right? Or maybe they're in a job, for example, certain healthcare professionals or commercial pilots, where the only option their professional board may allow might be naltrexone, right? The other group where I've really used naltrexone is the group that has done really well on methadone or buprenorphine. They've been in remission, they've been tapering off, they're almost off, and they start getting worried. What happens when I'm totally off of my buprenorphine? Or what happens when I discontinue my methadone? I often offer them the option that, hey, if you want, we can get you on the Vivitrol as a safety net while you build up your coping skills, your confidence, your relapse prevention skills. And when you're ready and when you tell me, we can simply stop the naltrexone. I've also had patients who've been tapered off, have done well, and all of a sudden there's a new stressor, like they're moving to the old neighborhood. I've had that happen more than once, where a patient comes in and says, I'm gonna move back to my old neighborhood. I'm worried. Can you help me? And oftentimes naltrexone is a good safety net for these patients, right? As they sort of feel more confident, more comfortable. On the other hand, I mean, for everyone else, I think about methadone and buprenorphine in general, right? And the way I really think about, of course, patient choice matters. For pregnant women, pregnant individuals, we really think about methadone and buprenorphine as our first medications, and naltrexone, there isn't a whole lot of data. Patients with chronic pain requiring chronic opioid treatment, we do a whole other talk on it, but that's another one where we should be avoiding naltrexone and thinking about buprenorphine and methadone. In general, I think about buprenorphine as a first-line medicine, again, because it's safer and it's more convenient to the patient and about as effective as methadone. So I often think about buprenorphine as the first line while reserving methadone for more treatment refractory cases. That's sort of, in my mind, all things being equal, how I approach this. This is just a little reference slide courtesy of PCSS that compares buprenorphine and methadone. We're almost at time. So I think a couple of other points I really wanted to make. One is, how long do I stay in treatment? And my answer to that is always, like with all chronic conditions and chronic medications, one size does not fit well. But in general, I am certainly not going to force people to discontinue a medicine that's working for them. And if someone wants to taper off early in treatment, I am going to caution them against doing so. And I'm going to explore their motivations. Why do they want to taper off? And engage them around that discussion and empower the patient to make that decision. But in general, we want to continue the medicine for as long as it benefits, right? As long as it benefits the patient. And lastly, I will end with this note on possible role of integrated clinics, right? That if you're able to integrate, right, methadone within, general medical care and psychiatric care within an opioid treatment program, or you're able to integrate, and this is probably more pertinent to many of you in the audience, if you work in a psychiatric practice or in a general medical practice, and if you're able to integrate treatment with buprenorphine or naltrexone within that practice, we can create these integrated systems, which do tend to improve outcomes for our patients. And it's a great way to provide that patient-centered whole person care. So something to think about, and I'll stop it here.